Pitter patter goes my heart. I'll call the Board of Health to order. Anyone online or here in the boardroom with us who would like to address the Board of Health? Hearing none. I get an approval to approve the minutes from the December 4th meeting.
So moved.
Second. All in favor?
Aye.
And you have just hopefully received the January 20 joint board minutes. Take a moment to review them. Comments? But the presentation staff made was very good. Cheers. Greatly appreciated it.
Great. I'm impressed they do that out in the community as well.
Yeah.
That is good move.
Yes. Can I get a motion to approve the joint board minutes?
So moved.
Second? All in favor? I oppose same sign.
Aye.
Mr. Forte, you are ready to receive your report.
I am ready. Thank you for being open and willing to receive the health report this morning. First off, I want to thank Carrie for a great all boards dinner and all of the logistics that went into it. So thank you, Carrie.
You're here.
Great as always. Next, for those who were able to attend, you not only got a belly full of great dinner, you've got a mind full of all of the amazing impact that we've been able to have across the community in 2025. And so I put that in your board packet this morning as a year in review. Really a year of impact and innovation for the board to consider. All that we've been able to do to take care of our teams, take care of our community, and continue the great work that we do. And so you all have that for your review and education. I think the biggest news, well, second biggest news in January, the first biggest news is that later today, Montana DPHHS and a coalition of partners will be kicking off the Montana's version of the Rural Health Transformation Program, RHTP. Over $233 million investment well, it's not an investment, but it's a cash flow that's coming from the federal government to help out for the losses incurred when you take $100 billion out of a system and only put $50 billion back in. It's hard to call that an investment. But that is what's being done. We'll get $233 million over the next 5 years for enhancing rural health across the state of Montana. We have representation not from RiverStone Health, but from Confluence Public Health Alliance, Montana Primary Care Association, the Montana Hospital Association, and we've got an inside man with Big Sky Care Connect. And so we'll be looking at what happens today, how they go about trying to get this money out into the hands of successful organizations across the state and being hacked. There it is. Sorry, I had a technological blip there. So we'll look at how that money gets across the state, and we'll find out more later today on what next steps are going to be and how we at RiverStone can get some of that funding to improve and enhance access to care. Second biggest news in January is that we will be moving, starting next week, into our new Healthcare for the Homeless clinic at the Montana Rescue Mission. It has been a night and day difference in the collaboration and the function 2 blocks down the street at the mission. And we're looking forward to opening our Healthcare for the Homeless clinic right there starting the first week of February. So
When will the schedule be, John? How often will that be staffed?
they're going to be there, Eric,
5 days a week.
5 days a week.
Excellent, Eric. That's great.
So
I'll be honest, when they get out on the mobile unit to go and do some outreach, but somebody will be at the site 5 days a week.
it'll not only expand access, but I think it'll open up new access that we haven't had before, particularly for those folks that are at the mission, receiving
Which building is
services.
that in?
And so the brand new mission building,
Yeah.
that's there right behind that where their daycare is.
Okay.
There's an auxiliary building. That's where the clinical will be, right on the first.
Eric, do they have an eligibility worker there? Does Medicaid keep an eligibility worker there by any chance?
Medicaid doesn't, but we do.
Okay.
We do that for our patients.
Yeah. Excellent.
So all of our folks that are in that program, they're trained to help assist those patients on
And Medicaid
eligibility.
allows it.
Yep.
Yeah. Awesome.
Yep. So, also coming up, next week, next Thursday, is our annual point in time count, so that we can get a better handle on how many folks are out there living unhoused and on the streets. So if you're ready and willing, between 4 p.m. and 12 a.m. To volunteer with us, we'll be out there on the street. I'm actually going to be able to help out this year. So I'll be out there figuring out how many folks we have on the street. Right now, we know our healthcare for the homeless patient population has almost doubled year over year. And of the 600 individuals that were counted last year, we know that number is probably in the thousands. And so we're going to continue to try to get better data and better numbers for that.
Where do they go? I remember in some of the library, but do they move around?
Folks are all over. Yep. Transient, west side, east side, downtown, uptown,
Yeah, okay.
in the heights, you name it.
Okay.
Yep. Could be anywhere, and that's living in cars, couch surfing, living under the bridge.
I mean the volunteers.
All the volunteers everywhere.
Okay.
Yep. So we'll go anywhere where folks may be.
Yeah.
Another important update for the board, our marketing firm that we outsource to called Flying Horse Communications has let us know that they'll be closing in the next several weeks. So our communications team reached out at all of our collateral, all of our materials that they've created for us since, the early 2000s. And they're going through all that to make sure that we get our information. We'll have a bit of a budget left to use on one-off marketing and communications campaigns if we. Other good news is that we'll be finishing up second round interviews for our communications and marketing director this week and early next week. And so we hope to have a full-time person replacing Casey Page after she went home to Washington. So we're going to continue to work on that and get our message out. I did share 2 brand new ads that we were able to do with Billings Met Transit. One is a bench outside of Billings Senior, advertising our services at the school-based health center. And the next one is a bus ad on the back of a few buses here in town. Michael?
Materials from Flying Horse, will we be able to use them?
Yes, they're ours.
They're ours.
Yes. Yep. That's one of the important reasons we want to get it all back. It's because it's our stuff. It's our collateral. We're going to talk about kratom enforcement later today, but just want to let the board know as of January 1st, we are beginning enforcement of Montana law. We're closing a regulatory gap that allowed kratom to be sold in retail food establishments. And so much like charcoal, nicotine, cannabis, oil, turpentine, you name it, if it's an unapproved food additive, it can't be in the food supply. And so we're going to continue to monitor and prohibit unsafe food additives and adulterants, such as kratom, from entering our food supply. And so we'll talk about that in much more detail later on.
Just for me personally, thank everybody that worked on that to make that happen. It's great.
Thank you. Thank you. And so, we'll talk about all of that. Is that, regardless of, there's two arguments happening right now across the country and across our state. And one of the main national arguments is this debate and frankly civil war between industry over natural leaf and 7-OH, which is a naturally concentrated version of kratom. It's not synthetic. And so you have the natural stuff, which contains 7-O, and then you have the isolated natural concentrate that is 7-O. Folks want to get concerned over what's better for society. That's not our debate. The debate is kratom, period, containing both substances in its natural form, is not allowed in the food code, not allowed by FDA to be a food ingredient. And so it's not an approved dietary supplement, it's not an approved dietary ingredient, and therefore any food or beverage with it in is considered adulterated. And so that's the FDA stance, that's the state of Montana's stance, and that is our stance. So with this enforcement that we've been able to step up, health departments all across the state have found the will to also step up enforcement and move across their jurisdictions where they license food establishments and take similar actions.
But that only partially removes the problem.
Correct. And so the Board of Pharmacy will be meeting at some point in the next month in February. And it's our goal that they will reach consensus and they will schedule or take action on 7-OH, the concentrated natural alkaloid, and that we'll be able to take additional actions to get that out of places where we don't have jurisdiction. So that's the end goal.
Any idea how many outlets are affected by the current?
Out of over 1,100 food establishments, we estimate about 30.
Does that include coffee shops?
Not coffee shops, but
Even if they
kava bars. Yeah.
Even if they serve snacks and stuff?
So any food establishment. Yeah.
Okay.
Yeah. But we don't know of any kratom being sold at coffee shops. Yeah. And so we'll talk a lot more about this with the public health presentation later this morning. But I keep trying to draw the connection between this new emerging opiate in kratom and what the Sackler family did in Purdue Pharma. And the opiate epidemic killed over 500,000 Americans. And this is just a similar situation. It's a new opiate, replacing one opiate for another. And as long as we keep dragging our regulatory feet, people will keep getting addicted and hooked to a new substance, and more harm will occur. So the lesson from the OxyContin issue is that regulatory bodies hesitate to take action. Addictive industries move more quickly. They claim that their product is natural and healing and therapeutic, and the public always pays the price. And so that's not going to happen while we're monitoring the situation. So we're going to keep taking action. Additional work in the clinic has occurred to improve documentation. I mentioned this to the clinic board last month, but wanted to let the Board of Health know we should see about an estimated $200,000 in savings dividends due to our value-based care efforts. We have more work to do, that is for sure, but it's a good recognition of the clinical team's efforts in our clinics across the region to provide excellent care, to take care of more chronic conditions and more comorbidities across our patient population. And so as we're taking better care of those patients, as we're monitoring all of their conditions, the Medicare Shared Savings Program is giving us more credit for taking care of those patients. And so we get shared savings payments with our community health center partners across the state, and that is our portion. So more money is on the table if we can take better care of our chronic condition patients. We've also narrowed down the search for Chief People Officer. We have 2 candidates coming in, one tomorrow and one coming in next Thursday for in-person interviews, and we'll be hopefully making a selection for a new senior HR leader. Lord knows we need it. Online patient scheduling continues. Really good feedback from our patients who are able to schedule same-day care appointments online, as well as make immunizations appointments online. So if you're traveling and you need a vaccine somewhere, to go somewhere, you can go online, schedule an appointment, and come in and see our public health immune staff. Just a short blip, a couple weeks ago, January 5th, our primary internet provider and phone service provider reported issues. They actually had a fiber optic cable down in Wyoming that broke and impacted our system. Our computer systems went over and switched to their backups really nicely, thanks to Bob's team and IT that has made incredible adjustments and additions to our infrastructure. Our phone infrastructure has been delayed in upgrades, and so that one failed completely. But thanks to the team, we were only down for about 24 hours or so, and we rolled phones over to alternate devices, and we were able to get everything restored by the next day. So small blip in access to care here, but we did okay, all things considered. If you know students who are interested in a future healthcare career, this is their chance. They can join us for MedStart Camp with the AHEC here in Billings, June 14th to 18th. The link is there to sign up, riverstonehealth.org/MedStart. We also have a Head Up camp that we'll be offering this summer too, if students are interested in behavioral health careers. We are underway with our transition from contracted security to a more in-house role. John Jones is transitioning into the role of campus navigator and security manager, safety manager. And so we'll be enhancing our security model, getting some more folks in-house that we can manage quality of the safe services that they provide, monitor safety and security on campus, and make some enhancements to physical safety here on campus. One of the biggest things that will help us with that is the elimination of the Colonial Building, and so that still remains. We met with the state attorney yesterday and are working through the final evictions as well as the final terms of our agreement to get that property taken care of. So the final eviction trial takes place next week, and we should be able to move forward, hopefully, in early February. I'm going to be really disappointed because Eric and I are going to DC the first week of February. And if they start taking it down then, I'm going to miss it. We continue to work, speaking of going to Washington, D.C., work with our national organizations to continue to get national recognition. And so beginning in February, when we go to Washington, I'll assume appointment as a vice chair of the National Association of Community Health Centers Legislative Committee, as well as vice chair of the Teaching Health Center Graduate Medical Education Committee. And Dr. Littlefield just completed her appointment as chair of the NAC Clinical Committee. So we'll maintain some leadership positions within NAC. And then we also kicked off this Monday recruitment for our very first APP, Advanced Practice Provider, NP and PA residency. It's the first in the state, it's first of its kind, and we hope to bring in 2 NPs or PAs a year and help train them, give them the experience they need to be independent practitioners. And hopefully they'll stay with us. If not, they'll continue to benefit Eastern Montana or a rural community in Montana throughout their career.
What background do they have to enter that?
You have to be a nurse practitioner or a physician assistant, new grad. So
okay.
there is no requirement for a residency for nurse practitioners or PAs.
Okay.
And so this will help provide some of the necessary clinical experience, close the training gap between E and APP.
Right.
And I'm sure Dr. Littlefield will add more during her report. We are also happy to be the lead agency sponsor in United We Read this year, next 2 years. If you want to volunteer on Friday, March 6th, join us as we read across School District 2. Go out to schools and share the gift of childhood literacy. We know that there's a direct correlation between childhood literacy and health outcomes and safety and security in our communities. And so that's why we're taking on this initiative. At our annual meeting, I shared some of our good turnover data that continues, and we were now able to compare ourselves to our HHS, community health centers, public health agencies around our region, Region 8, as well as nationally. And we continue to do great work with our culture and keeping our staff engaged. You can see in the public health world that flu continues to rise and peak. If anybody has any kiddos or family members around with upper respiratory systems, it is the season. So wash your hands frequently and take care to isolate if you're sick. And then I just want to share a shout out and kudos to our epidemiologist and public health team. Taylor Cook and her team created this Yellowstone County Injury and Overdose Dashboard, which provides some really great data and information. We continue to fine tune our data, and I'll share later in our governance report on how we're creating new KPIs and dashboards and information. And so as we continue to move forward organizationally and mature in our ability to get good data and information, we'll be sharing that to the public and to the board in a more cohesive way.
Is that available on the RiverStone website?
That is right on our website. Those are screenshots from the website. Yes. And so that's accessible at riverstonehealth.org, and you go to our community health page and click on injury and overdose data. The last thing I'll just allude to, and again, I'm sure Dr. Littlefield will mention, that nothing changes in terms of the childhood immunization schedule as far as we're concerned at RiverStone Health and within the state. Access to vaccines remains, and there will not be any vaccine changes in terms of availability or insurance coverage in 2026.
Any questions for John? Any more questions for John? Hearing none. Dr. Littlefield.
Right. I just have a verbal report, so I apologize for that. Just to touch base on a few things that John mentioned as far as workforce is concerned. We have hired a new NP, but we have lost an NP in this month, one who's resigning. So we're still recruiting. We have open position, 2 open positions, I believe, for mid-level providers. We finished up our residency interviews. We interviewed over 100 residency candidates. We're recruiting for our spots here at RiverStone and also the 2 rural track positions. So we'll be submitting our rank list in a couple of weeks, and the match is in March. So more to come on that. Our MA staff is getting stabilized. We've talked a little bit over the last few months about being really short in our MA workforce. We're getting there. We still have, I think, 5 open positions. We're close to being able to staff 13 providers at a time at the main clinic, and still working to increase our ability to support more. We're also working on an MA training program that is also in development, sort of similar. I think we've had really good success with growing our own in our residency program, and I think continuing to look at other areas in medicine that are short-staffed. So our medical assistants, our dental assistants, even positions in public health, as much as we can sort of start to think about how do we develop those workforce tracks here. It not only helps us as an organization, but it also helps us to ensure that people who are out in our communities are getting a really good training. And so we're continuing to work on that. And with the APP residency, we are on target to start this next year. The structure of that program is going to be sort of similar to the our physician residency, but it'll only be 1 year. But we're going to have 4-week block rotations. So they'll have continuity clinic, because the main thing that our APP residency is going to be focused on is training highly trained primary care providers. So they'll have a continuity clinic here, but then in 4-week blocks, they'll have a focus in a different area. So we are going to get them some inpatient training with our inpatient team. We have 2 of our APPs who work with our residents and faculty on the inpatient team already. So we'll get them some training with inpatient experience. They'll rotate through our Hep C, some of our specialty pediatrics, school-based health center, addiction medicine, our procedure clinic. So they'll get some increased focus in different areas of primary care in 4-week blocks. And then, of course, attend the didactic sessions and get some other more direct precepting and hands-on training with our APP faculty. So that is really, really exciting. As far as clinic changes, our spirometry clinic is up and running. Spirometry, I'm not sure if I talked about this the last time, but that's function tests that we do to look at people's breathing capacity. You use it to evaluate people with asthma or COPD and emphysema, and also to sort of stage their disease year to year. We had a spirometry clinic prior to COVID, and then COVID happened, and really everywhere shut down this office-based capability because of the risk of COVID spreading. And then by the time COVID had sort of resolved and these clinics were starting back up, our equipment was so outdated that we had to get new equipment and figure out a better structure of how to do that. And so that is up and running, and that's very exciting. We were having to send people up to the hospital for formal pulmonary function tests, which oftentimes people don't need. full pulmonary function test, but it also was really a barrier to care. So we have a number of patients that we have some catch-up work to do to get them back to where on schedule with that testing. So that's exciting. We are working on a different scheduling system for our providers and for clinic staff called Lightning Bolt that is going to have some automation involved, and hopefully will make that be streamlined and easier to manage. From a public health standpoint, just to touch base quickly on the immunization issue, because this has been sort of a hot topic in the press. The big thing that happened, so there is a committee that's called the Advisory Committee on Immunization Practices that was established in the 1960s to give guidance to initially the Surgeon General and then the CDC on what are the immunization practices we should be recommending across the country. As you heard so that typically was a group of people that came from various different industries: public health, epidemiology, pediatrics, research, pretty much all of those, infectious disease, and committee members would get nominated or nominate themselves. There was a really sort of strict vetting process that people went through to get selected to be on that committee to make sure that there weren't perceived or personal conflicts of interest to serve on that committee. The people served generally a 4-year term, and they were overlapping. So the committee that was there would sort of help to nominate and vet new people coming onto the committee. And the head of Health and Human Services would be sort of the final decision maker of who was on that committee. If many of you recall, when RFK came in, he fired the committee of, I think, 18 people at the time and appointed 8 new people. And it wasn't really clear how those people were selected to be on that committee. There was a lot of concern that many of the people who were appointed on the committee were previous people who had been outspoken against vaccines. And there was not the same presence of public health and pediatric experience on that committee. One of the first things that happened with that committee was they made changes to the universal recommendations of hepatitis B vaccine. And that happened back in December, and that caused a lot of conversation in the press. Then what happened a couple of weeks ago is the CDC or HHS came out with changes in the universal recommendations that decreased. We had been recommending 17 different vaccines, 17 different diseases that we were protecting against, and that was a universal recommendation, and that was decreased to 11. And the big conflict with that was that decision, that decision circumvented even the new ACIP. So typically what would happen is the ACIP would be called to have conversations about changes to the immunization schedule. There would be, conversation, debate. Sometimes it would go to sort of open conversation, open comment to the public and other experts, and then the recommendation would be made. This recommendation came out, completely circumvented that process. It's not clear who it was that set these recommendations. And what they did was they divided, so there were all of these vaccines were universally recommended, and they put them into 3 different buckets. Universal recommendation, so still MMR, DTaP, polio, sort of some of those diseases that we think about as being like the main vaccines. Nothing changed with those. Those are still universally recommended across the board. But then they put 2 other tiers in there: a high risk vaccines that are only recommended for high risk individuals, and then vaccines that should be part of a shared decision making with a medical provider. Which, to be honest, is a little bit silly because all vaccines are shared decision making with medical providers. That is something that is part of my regular job as a primary care provider. If you have a patient who is concerned about a particular vaccine, being able to talk to them about it and help to decide if it's the right thing for them to, take. No one just gets, unless you're in the military, no one just gets vaccines without knowing what they're getting and without the opportunity to decline that vaccine. And so, but what it has done is the AAP, the American Academy of Pediatrics, came out and said, we're not following this new recommended guideline because it didn't go through the process that it normally does. It hasn't been vetted. It's not clear why these changes were made. They were based on peer nations that are very dissimilar to us, like Denmark. You can't compare America to Denmark for a whole host of different reasons. And so the AAP has said we are going to continue to follow the previous vaccination recommendations. And so we now have these two different guidelines that are out there that patients and providers need to navigate to try and explain why there are these two different lists of recommendations. And then the other thing that is, I think, a problem with this is that not that we shouldn't relook at vaccinations. There's new research that is coming to light all the time. And I think that it is appropriate for us to think, do we need to have one dose of HPV, or do we need to have 2 to 3 doses? If one is adequate, let's just do one. We should be reevaluating this. The issue is how this was done and whether it was really done in a scientific manner. And there's a lot that's being called into question with that. And it has really fueled this vaccine fear. And that's what I think the majority of public health, primary care, pediatric folks are worried about, because we have already seen a distrust of vaccines and a sense that vaccines aren't safe and that we're just putting vaccines out there for the sake of getting vaccines out there and that they haven't been vetted appropriately for safety before we are recommending them. And we're worried that we are going to see this trend into increased vaccination declination and poorer vaccination rates. So as a clinic and as an organization, we are still supporting the AAP recommendations. We are working on a process that really does allow patients to recognize the different tiers so that they know that we are open and willing to have conversations about this. As an organization, we are going to still primarily recommend the AAP now recommended vaccines. So that's the big shakeup in the immunization landscape. Any questions?
Besides measles, has anything else popped up in the country?
Well, we've seen a lot of pertussis. So pertussis has really been circulating a lot. But those are the main things that we've seen.
So how much time will your AP residents spend with the medical residents?
So they will do didactics together, which we already do with our new grads that come in, and then they will. So the faculty are going to be different faculty than our physician faculty. Mainly because we don't want to for 2 reasons. First of all, I think that you learn better from your peers. And so I think it's important for our really well-trained, experienced APPs to share that knowledge and leadership with people who are in their peer group. And it gives them an opportunity for professional development. But we also don't want to overburden our physician faculty who already have a lot on their plate. And we don't want to, and we're being very careful to not take away from the experience of our current residents. And so the way we've staggered rotations, we're making sure, so like our medical residents spend time in public health and do a public health rotation. Our APP residents will also do a public health rotation, but they'll do it later in the year so that it doesn't overlap, so that it doesn't impact the residents and it doesn't overburden our public health team who's having to, come up with programming for them.
Yeah, so I now look at delivering medical care as a team sport.
Mhm.
And I'm just wanting the medical residents to be comfortable with it.
Yeah, and I think our APPs work so closely with our faculty and residents in our continuity practice and now on our hospital team that I think they naturally get that, but that will be part of what, we'll build in.
Is that excuse me, is that an accredited program?
Not yet. That's a great question. Not yet. There are accredited programs across the country, and our plan is to get this up and running, and then work towards accreditation. The accreditation process, thank God, is not as arduous as our medical residency accreditation program, and so we don't think it's going to be as much of a lift, but we kind of want to get it up and going and stabilize it a little bit before we pursue formal accreditation. But we're hoping within the first 2 years.
You mentioned you're going through applications for the residency program. How was the level of interest for the residency program this year?
It's been good. I mean, I think we started with something like over 900. I mean, we started with one of the things that's hard, and this is true with college admissions too, is now that it's all a click of a button, you can, people apply, to 30 residencies, whereas back in my day when you had to hand type out your application, you got to 5 and you're like, I'm calling it a day.
And I did it with Stone Tablet.
Exactly. And so, so we get a lot of applications. It is not always clear what the true interest is. Garth and the residency leadership team has come up with really a great process of how to go through those applications, looking for people who are from this area or from rural areas, people who have demonstrated interest truly in family medicine, because the other thing that happens is a lot of people will use family medicine as a backup residency, but they really want to go into orthopedics or surgery or ED. You can sometimes tease that out because, you read their personal statement and they haven't changed it to say family medicine. So you can kind of tease out some of those, pull out some of those people, but they've done a really good job of cultivating. And then we really only offer interviews to people that we think are candidates that are good candidates and interested in coming here.
How many slots will we try to fill?
We'll try and fill all of them. There's a high likelihood that we are going to need to go through the second match process that we formerly called, which now is the SOAP program. It formerly was called the Scramble. We're fully expecting that. We've had to do that the last couple of years. There have been fewer and fewer people applying to family medicine. We're a rural community program. People aren't visiting, the way they used to. And so, so we're fully expecting to have to SOAP for some. But I will also say that SOAP process has gotten us some of our best residents. And so, I think it used to, even I used to feel like, gosh, if you have to scramble, you're not going to get as good candidates. But then seeing over the years, some of the people that we have gotten through that process really have been some of our best residents. And so I think now Garth goes into it just fully expecting that that's going to be part of what we do, because we've had to do that for the last, 5 or 6 years, I think.
Any other questions for Megan? Hearing none, thanks for the report, Megan. Finance is up. Spencer and Shannon.
Shannon, you want to pick it up?
I have 40 minutes, right?
Yeah.
All right. In the packet, we have October and November financials, but I'll just really concentrate on November since that's the most relevant information and really just highlight key performance indicators and information contained within that piece of the report. Circling back to days cash on hand, at the November cash total about 14.2 million. Of that, 4.4 million is unrestricted. Of that 4.4 million increase. And so that's days cash on hand, about 76.87 days cash on hand. Put that in perspective, last year at this time, we were at 34.38 days cash on hand. So pretty significant increase in that as we continue to work towards that goal of 84 days for this fiscal year. At the end of November, we did have a balance of deferred revenue of about 2.3 million. We still have some COVID funding in there, about 545,000, and that will be used for the mobile unit payments as we continue that lease structure. So all of that's been allocated out. And then we do have 182,000 from Montana Healthcare Foundation for school-based health and about 149,000 from Fortin Foundation for mobile unit operations. We did receive the other $200,000 from Fortin Foundation within our foundation within the last month or so. So we have a little pot of money related to that piece. Our grant drawdown process is up to date. We haven't had any blips or issues within any of those systems as far as that goes for reimbursement. And then just to concentrate on a couple of things as it relates to revenue and expenses. Patient services revenue was under budget for the month, about $160,000 for the month of November. That really continues to be concentrated in Medicare Advantage and Medicaid as far as those variances go throughout the fiscal year. Other revenue, we continue to have pretty decent collections on a recovery of uncollectible accounts. So we're over budget a little bit within that in the month of November, as well as year to date, but over budget about $72,000 in the month of November. So if we're looking at our bottom line for November, we're at a bottom line of about $258,000 compared to a budget of about $23,000. The bulk of that variance is, like I just mentioned, things like the other revenue from the collection of bad debt, but really where we're seeing that variance is in our salary and benefits. For the month of November, we were under budget $303,000 in salary and benefits due to vacancy savings. So that really does continue to be the driver for us in the bottom line, even through the fiscal year. When we're looking at year-to-date variance within salary and benefits, we're under budget about $1.1 million. And then just to put that in context, if we look at where we're at year-to-date, bottom line, we're about a positive $1.6 million compared to a budget of about $95,000.
Okay, so you left me 36 minutes?
36 minutes with you.
I teased them before the meeting that we had a light agenda. They could work.
I think, if you'll turn to the key performance indicators for November, you can just briefly touch on them. I think that it underscores what Ken has already described to us, which is that organizations, we're doing well. We're the overall variance of 1.5 million to what we budgeted for the fiscal year is a positive sign. I think that if you're looking for cracks, I mean, the one thing that Shannon mentioned was the Medicaid, and Medicaid remains an issue for the organization. That's smoothed a little bit if you're looking at it, at the financial statements by our insurance and self-pay is over budget, so that's kind of compensating for some of that budgeted deficiency in the Medicaid space. But looking at the key performance indicators, that big red number is a good number, really. If you look at the overall graph, that's the trajectory is right on schedule for what we were expecting. So we feel really good about that. And our net revenue remains extremely positive. I guess if you're hitting your goal by over 1,000%, that's probably good. And then we do continue to do a really good job of accounts receivable, patient account receivable. So we're up under our budgeted goal of 45 days. This next section is, I think, real illustrative of the organization's overall performance. It's their net revenue by service line. We just focus on the year-to-date service line. You can see that the pharmacy, I mean, the only area where the organization is underperforming related to service line is the retail pharmacy, but when you take that in conjunction with the 340B pharmacy, they kind of net together to a net positive. So I think my impression is they kind of go hand in hand. So, but generally speaking, we're doing well from a net revenue standpoint. So I think the organization's year-over-year improvement, then we feel really good about where we are. Are there any questions anyone might have?
Just one more thing to add on the days cash on hand. We will see an increase in that in December with the collection of our mill levy payment. We get one in June and one in December, so we'll see our uptick in days cash on hand in December. Probably see it trickle a little bit in January, February, just normal cyclical operations, but definitely on track to get to that 84 days by the end of the fiscal year.
Comments or questions? Finance Committee? Hearing none, thank you for the report. Things look good. Safety and quality did not meet. Lionel isn't here.
I am here, actually.
Yes. Oh, Lionel, what's up, buddy?
Well, I'm only 1,300 miles away. Is where, well, so I'm with you, but not with you. I'm suffering through 78-degree Tucson weather.
You won't have the joy of a blizzard then tomorrow.
Right,
0-degree weather.
right. Anyway, as
comments you
stated,
wanna make
no
to the
meeting this
board?
month.
Any comments, Lionel, to the board?
No, we did not meet this month. We will be meeting next month. So,
Enjoy the golf. Enjoy the weather.
okay.
I forgot to get acceptance of a laundry list of financial issues here. Making a motion to accept the January 22nd meeting notes, the October 25 financials, and the November 25 financials, please.
Second.
All in favor?
Aye.
Thank you, Terry, for keeping me on track here. Brent, despite no meeting for public health, any comments?
Same report as Lionel.
I have a few comments to add, though, if I may.
Absolutely.
All right, from late breaking news on a summary for consolidated appropriations funding out of Washington, D.C. Earlier this week, the House released text of the new Appropriations Act, which includes FY26 funding bill for Health and Human Services and other agencies. We have good news. Overall, the bill provides $116.6 billion to HHS, extends funding for several key public health programs, and there is a bipartisan rejection of the administration's desire to cut public health funding and restructure departments across several different public health agencies. Primarily, our advocacy efforts paid off, and there is a bipartisan rejection of the way this administration terminated grants over the past year. And now they are being directed that HHS will need to, if this bill is passed, HHS will need to consult with key congressional committees prior to terminating any grant funding for agencies across the nation. Additionally, it is directing HHS to provide advance notification to congressional committees should they desire to doze around with the PMS, the payment management system, and make Shanna and Tyler, put in justification 6 ways to Sunday on why our funding is our funding and what we're going to correctly do with that. So lots of good news to look out for. Additional good news is that it provides level funding for the CDC. It provides level funding for SAMHSA, and it provides an increase for HRSA, which is really good news. It is going to potentially increase funding, again, if the bill is passed, primarily increase for teaching health centers, which is a welcome increase. It's not much, but it's what we can get in this current Congress. Excuse me. When my doctor told me the bacon would kill me, I didn't think he meant this morning, but it's back there somewhere. And it also gives mandatory funding increase for community health centers. Discretionary funding continues, but this would be the largest funding increase for community health centers in over 10 years. And so we're going to continue advocating for the bill as it is written and continue working with our congressional delegation to make sure they know how grateful we are for this bipartisan push, as well as the increases for our residency program. So good news out of Washington, D.C. in a time when it's hard to find any.
The bill going through is looking prospectively at funding coming down the pipe, correct? Not going back retrospective, correct? See what was canceled, correct? So those who were canceled could probably reapply, maybe?
Yeah, potentially. It doesn't, everything that's kind of been turned off legally is still considered turned off.
Okay. Thanks for that update.
Yep.
Governance Committee met. We had a variety of issues we wanted to talk through with John. Strategic planning, the Baldwin status, and our work on dashboards and performance metrics. I'll let John speak to those points.
Still not.
Absolutely.
Thank you. Yes, we had a good conversation. Last governance, we've talked in the meeting as well as with the clinic board on how we want to have and go through some strategic planning exercises with both boards this year. And so we're going to have an internal conversation on goal setting and strategic planning with our cross directors group of middle managers and senior leaders in the first week of March, I believe. Right, Eric?
Yep.
Yep, good. And so after that session, we'll be putting some guardrails around what it looks like to bring the board around the table and talk about what we may or may not have capacity for, get your perspective on ideas for enhancements and strategic directions, and work with both the clinic board on what that looks like for the clinic and clinical care, as well as the Board of Health and what that looks like for the greater organizational overview. So
John, before that meeting, are you going to ask board members for thoughts?
yes. Okay. So we also have the opportunity, we have some internal expertise for potential facilitation of such a session and some brainstorming. And so we'll be able to hopefully do that in the early stages of the spring. So on the Baldwin status, we talked several months ago now, almost a year ago now, about our transition from, actively chasing Baldrige recognition to actively doing the work within the organization and building the infrastructure, the policies, getting the leadership infrastructure built across the organization so that it was even something that could be attainable in the future. Not a person across the organization that was outside of this board has any understanding of Baldrige or what that means or what it would do for the organization. And so instead of chasing a shiny object, we are putting together all of the necessary tools, infrastructure, leadership, conversations, across the organization so that maybe someday we're there, we're ready, we're there to chase the recognition.
Isn't that a little bit like a Nobel Prize?
Yeah, yeah. Give it to me. I love it. And so we're going to do the work that we need to do and build your strong internal organization and the infrastructure that we need to keep maintaining a successful organization with, the goal of someday before I retire, maybe being at a point where, we feel we're ready to fill out that application and get recognized for the great work that we do. And then on that note, part of that process is getting all of the dashboards and the KPIs, the key performance indicators, not just for our finance committee, but for operational committees, for safety and quality, for legislators, for others, so that we have the data available. So Bob and his team are actively, building out we're going from the data swamp where we have a crap ton of data and nowhere to put it, to the data warehouse where it's all being organized and categorized, and we're building trust in the numbers and figuring out where the data is coming from and what it means. We're in a place right now of, garbage in, garbage out. And so we've hired a sanitation crew to come clean up the trash and work through the data with us so that we can have better information to share and make better decisions based off of that information. So we will be bringing to the board over the next several months, not just financial key performance indicators, but others that impact the organization and all departments, so that we can continue to move towards this performance-based management system.
Questions for John?
No, maybe just a comment. That seems great. I mean, I support the idea that maybe Baldridge takes a backseat to the effective or efficient, gaining efficiencies and effective work that's going on. And the strive to add more metrics, more visual representation of the overall organizational performance is important too for those of us on the board that aren't involved in healthcare on a day-to-day basis.
Yeah.
So.
Other comments?
So my thought on that is that to get to the Baldridge was a heavy lift, to do it all at once. And so I think that this method or this approach, allowing the organization to improve over time before really launching off on that last, push to the summit, it sounds like a really reasonable thing. So I agree with the idea.
Thanks, Lana.
Yeah, I was trying to think of dates here, and 6 years ago this month, the veterans on the board and the staff, we were starting to realize that COVID was coming and we didn't know what it was. We were in the depths of Baldridge, but Baldridge had to be put on a bookshelf for a few years. The organization, all providers went through a tough period for a couple of years with COVID in the country, until vaccines were available and people were vaccinated and disease started to get under control. And the organizations all the providers had to recover from the financial stress they were under, from lost patients changing their referral habits. That was a lot of the financial stress felt. So we are still getting our feet firmly planted back on the ground. The financial report we just saw resonates well. The turnaround in the financial results is outstanding. So, enough said. Any old business to come before the board? Melissa, you snuck in there behind me.
Sorry.
No, we're always short change on time. I'll give you till about 5 till 9 this morning, so I can then get the conflict of interest done.
Okay. You guys, are you ready for this?
Oh, yeah.
Oh, gosh, I was 8:30. I thought that was early.
You didn't,
Okay,
it's a brave new world.
okay.
You need to action on the board schedule meeting schedule?
Yes. I was gonna let Melissa go first and then we'll do the,
Well, I'm pinch hitting because Nikki Peterson, our new food program manager, was really excited to be here and present. She's slowly taking on this project, but she's out sick today. So I think John is gonna maybe project a few of the items that were in the board packet.
You got it. Let me know what you want to see first.
John, if you could make it so I could see them too, that'd be great.
Yep, that's what I'm working on. Thank you.
Let's start with the courtesy letter. So John and Carrie had asked us to come and give an update on kratom enforcement. We aren't going to go into the dangers of kratom. We've spoken to this group before about that. I know the Public Health Policy Development Committee has heard that quite a bit. So we'll just give an update on where we're at. So as you may recall, we educated our community for about a year that kratom is not allowed in the food code or the Montana Food, Drug, and Cosmetic Act. We let them know, be prepared, enforcement may be coming. That was the year we needed. We needed that time to see if the legislature was going to make any bills, to get our county attorney on board, to get ourselves work with Crowley to make sure that we were doing our due diligence. And of course, to work with state partners to understand that this was very much in our scope as the public health department and not challenging the new legislation around health authority. So we did spend that year, and I will say that a few of our large C-stores, specifically Town Pump, when they got the application a year ago, they said, great, sounds good, we'll pull it out. So they actually removed it from the entire state before any enforcement action came through. So then what we decided to do, we went back and forth about how to move forward with enforcement in the new year, and we decided what would be the most fair to all of our retail food establishments is that if we sent them a letter saying starting January 1, new enforcement year, new license year for businesses, that is when we are going to start truly enforcing this. And so we sent this courtesy letter out in late December. I wish it would have been sooner. I think it would have been great if we could have, but ultimately due diligence, we weren't willing to sacrifice that and we needed to get it out. And so the letter clearly states the current status of kratom products. It calls attention to 7.0, but highlights the fact that we are focusing on the food code, which doesn't approve it, period. And so basically what this letter says is you need to remove the products and any promotion of these products from your business. And if you don't do so, we are going to move forward with an injunction through the county attorney's office and or license cancellation. So typically when an establishment is out of compliance, we have a 3-strike rule. We'll go back a couple of times. We find it each time and we can pull up the enforcement flow chart. After 3 strikes, we'll let the state know, hey, as your local boots on the ground, we do not support the validation of this license. That's an important clarification. We are not the ones who license businesses. It's DPHHS. But the Montana Food Code and the Montana rules and regulations give us the authority to be their inspection arm. And so what gets a little tricky is we then have to say to them, hey, this isn't passing muster. You shouldn't issue them a license. But it's still their discretion and their decision on if they move forward. The way that we have Montana Public Health Authority structured in Montana, we're a very decentralized system. And so they really want us to handle it locally before it goes back to them. So that's why the injunction process handled through the local county attorney's office is likely to happen first before license cancellation. And that gets a little funky and we're figuring that. So what we're doing is as we're going into inspections in the new year, they are predetermined dates based on an establishment's risk level. So it's risk level 1 through 4. Higher risk level 3, 4 means that you have a more complicated venue or you're serving foods that are just a little bit more likely to cause foodborne illness. So we'll go into those places a minimum of 2 times a year. And then anytime there's a complaint or an investigation we need to do. But risk level 1 and 2, we only go in once. And like I said, it's predetermined. So if we went in August last year, we're not going to go back until August again this year until we hear a complaint. So our sanitarians are starting to go into establishments. Like I said, we hit reset on January 1. And this is the guidance they've been given on all the different food codes that Kratom violates. So we have, we talked about it here. Montana adopts the food code. The state legislature will be considering adopting an updated version of the food code from the FDA. So that's going to be a really important process. But they adopt a model food code that the FDA gives us. I think we adopted ours in 2015 or 17. And that clearly states where food can come from, what's considered a food establishment, so on and so on. But the ones that we're really concerned about related to Kratom are that food needs to come from an approved source. There is no approved manufacturer for Kratom. We know that 90% of products are imported into the United States from Southeast Asia, and they're not imported as consumable foods. And so that's already problematic. So we'll mark it out if it's not from an approved source. If it's adulterated or not honestly presented, or if it's just not considered safe, we'll mark it out as well. The FDA clearly says that Kratom is not approved for sale due to its safety concerns. So there's that strike. It's adulterated because you're not serving people the Kratom leaf. You're serving it in a beverage, in a drink, in a hot, like a fruit punch, in a little shot. So it's already been adulterated. And the honestly presented, there's no clear medical claims, right? It hasn't been vetted by medical authorities. And then finally, because the FDA doesn't approve it as a food ingredient, it's not on our generally recognized as safe list. It's not considered allowed in your food system, and that includes beverages. There are, in the Food, Drug, and Cosmetic Act, ours in our state does dictate supplements, and was not approved as a supplement in the state of Montana, and so therefore none of that applies to Kratom. And so what we have people do is we're not having them say, okay, if you see one violation, mark it out. We're having them mark out every single violation they see because we need to be able to tell the story of why Kratom is problematic in these places. So if you want to keep scrolling. This is a little hard to see. Fun fact, it's actually a lot better than our old enforcement chart. But this is just the process that we follow when we are going through this piece. We've shared the process with our respective governing authorities, sharing it with you today. We've also shared it with the media and with some of our establishments because they've asked. So basically, this is what our standards process looks like, and then we've added in the pieces regarding Kratom. So we go in, if something is out of compliance for the food code or for inspections, we'll mark it down, and depending on the severity of the risk, that dictates when we're legally required to come back. So this is all written in food code. Most high-risk violations, Kratom being one, we're required to go back within 3 business days. So it's actually a pretty rapid process. Others fall to more of a 10 business day process, and some we don't actually go back. They can submit a photo or they can submit a work receipt. So if there's cockroaches and it's not in the food area, it's just in the back or something, they can submit a work order from an approved vendor, and we would document that. So we'll go back after 3 days and see if the Kratom remains. If it remains, then we're going to give them a notice of violation and a $100 fee and say, okay, we'll see you again in 3 days. So we go back again. That's the 3rd strike. If they are still out of compliance, then we're going to we will send them a letter notifying them that we'll be requesting their license cancellation from the state, and we'll move forward with the injunction process. To date, we are moving forward with this process for 1 establishment so far. So we reached out to our county attorney's office and the state to say, okay, we're ready. Let's make sure we have this right. One thing we've learned from the county attorney's office is it's going to be about 120, 150 days to get through that injunctive process. And so that is part of that clarity we're looking for from the state, is to say, okay, are you good with waiting that long to entertain canceling a license? Another piece that I think is really helpful, we've done a lot of work over the last year fostering our relationship with the city of Billings. They often forget that we are their health department just because we're not in their building. And so anytime someone doesn't have an approved health license, we'll let them know, because it's technically their business license is contingent on having a health license. So just trying to get ourselves all organized and coordinated.
And the goal is not to cancel a business license. The goal is to allow businesses sufficient time to change their business model and comply with the food code and food safety. And so there are businesses out there that are looking to skirt our regulations and enforcement. And then there are businesses out there that are willing to work with us. And which is, Melissa said, the 3-strike kind of system. If you're willing to work with us, we're willing to work with you, and we'll work on that timeline together. We're closing a regulatory gap. And so we know this is not the best possible interest of individual businesses, but when a business decides to partake in the sale of a new unregulated product, there are risks to that business model. And so clearly, there are certain businesses in this community that didn't understand all of the legal ramifications of selling food product that was unapproved and unregulated. And industry misled them into thinking that it was completely kosher, safe, and that there was no risk involved. And so we come in to be not the bad guys, but to be the truth tellers and operate in fact and operate on Montana law. And so we'll continue to do that and continue to work with businesses. There are certain businesses out there that want to skirt this by saying, oh, we'll become a social club instead. However, if you're a social club selling food product, you still have to be licensed by the health department as a licensed food establishment, regardless of what type of business you are.
And I would just add that it's been really encouraging to hear for every negative comment we get from a business or someone feeling like you're taking what really saved them on their addiction journey. We're hearing 4 or 5 stories or getting voicemails from people saying, this was so scary. I'm really appreciating you stepping up. Other health departments have really appreciated you all supporting us in moving this forward, because they now fall in line with it. So I talked to a lot of health departments as they're going to their boards of health to get that buy-in, and the consistent message is, thanks for figuring it out for us. And businesses, we are first and foremost a resource to them. Someone had said, do you really expect a business to know all these nuances of the food code? Definitely not. But that is why we ask, when you're starting a business, you do your plan review through us. You meet with us before you submit that, because that's where we've traditionally flagged a lot of these additives when people want to add charcoal or some random elixir type of thing. It's our job to do that legwork and say, you know what, not quite. And so what we are seeing is we've tried the education approach, but there are just a small handful of businesses that have said, I agree, I'm going to move forward. And so those are the ones that we're going to have to just have a little bit more of an intentional approach with, I would say.
And I appreciate the Board of Health support. I appreciate our local governing body's support in this effort, because we are going first. Every other health department across 56 counties, 55, looks to Yellowstone County. They look to RiverStone Health as big brother, big sister, because we are the most respected in the group of looking through these issues and being the role model for the rest of the state. And so we are working across the entire state with other health departments to say, yeah, this is what we found and this is a problem. And we are ground zero for the kratom issue. We've become one of the top 5 markets in the United States for this stuff. And so while it exists in other areas across the state, it is most prolific here. And that's why we're taking this on.
So the December 18th letter was mailed to all of the licensed food serving establishments. Is that it?
So we did an email, because with our inspection software, we can more easily access both the owner and the on-site supervisor.
And are there enclosures that were sent with that? Like the frequently asked questions or
No,
just the letter?
just the letter. And then as we're going in, we're referencing that. We're doing a lot of media, so it's kind of a comprehensive piece. We've been meeting with the distributors so they understand the messaging, because we ran into a little bit of that where there was a little regulation of messaging, intentional or not. And so just the letter, because we've done the education prior.
You mentioned Town Pump, and they voluntarily pick up. Are they food establishment also because the casinos? I mean, they just have a gas station.
So convenience stores, by and large, it's rare that a convenience store isn't a licensed food establishment, because
It is or is not.
it's rare that they're not. So they mostly are, because they serve food that's,
So they can, so like the gas stations, they can still sell it.
no, because they're a food establishment, they're not allowed to.
Okay. Who can still sell it like you can?
So right now, we're trying to figure that out. Our initial understanding was that vape stores, and I've seen a lot more reports of like craft markets starting to have these there. But DPHHS is clarifying their expectation of us to go into any establishment that's selling kratom as a food product. But since there is no clarity, we're not.
There's a lack of clarity right now across the state on if something's being sold for consumption. Does DPHHS have regulatory authority over that substance? And then would we be their enforcement arm locally to be able to do anything about that? And so there will be gaps, there will be things, there will be kratom products continuing to be sold up until potentially the Board of Pharmacy takes action. And they'll be in smoke shops, they'll be in, basements, they'll be in the backs of cars. And they will be in institutions and businesses and establishments that aren't regulated by us. They're, any non-licensed retail food establishment, technically. But there's a lot of conversation on what enforcement looks like and what agency or entity will ultimately be responsible for getting some of the other products off the shelves.
Melissa, earlier I said something, but thank you to you and your team for doing all of this. And from the letter down all through this whole thing, I very much appreciate the completeness and the logic of it. It's in 4 or 5 pages. It's a great presentation to other groups around the state, and it's fantastic. Thank you.
Yeah, it's been a great learning opportunity, and I think it's been a really great opportunity for us. We talk about being siloed as an organization, but we're siloed in public health too. And so for me, it's been awesome to work with our health officer, our epidemiologist, our health educators. We hosted a Train the Trainer this week for local leaders to understand how to talk about kratom in their communities. But then also the sanitarian. It's been great to see that holistic approach of the public health team, and our clinic has stepped up too. They're the first ones that have started coding for kratom and trying to document that to give us a little bit of a sense of the impact. So it's been a great project, sure, and most importantly, meaningful to the community.
From a clinic perspective, I just want to share, we've been talking about this for a long time. And, to be honest, when we first started talking about this, I don't know, a couple of years ago, we were sort of like kratom, kratom's problem, but we weren't really taking it that we weren't as concerned in at least our clinic about this. I will tell you, we are seeing such a huge uptick in people coming in who their main complaint coming into our, so we have a medication assisted opioid use disorder program here where we largely are using, treating, for morphine and heroin opiate addiction. We have seen a huge uptick in particularly young people coming in who are addicted to kratom, who are not using, oxycodone, they're not using heroin, they're not using like other opiates, but they're coming in using massive quantities of kratom and having a really hard time getting off of it. And we have been using Suboxone to treat people with kratom addiction. And I think there's a lot more of that out there. We just aren't seeing it because we haven't been able to code for it. We don't know the scope of this issue. We don't know how many overdoses there are because people are coming in, and because there's no way to easily directly code for that or to screen. Like a lot of our drug screens don't even include kratom, yet you have to specifically ask for it. And so because we're not able to do that yet, we really don't even have a sense of the problem other than what we are seeing. And there was one day that I was precepting that literally 5 people were coming in with kratom use as part of their, part of the reason why they were coming in. So it really is a bigger issue than I think we recognize.
Is the physiological response to it similar to an opioid? Is it the same as heroin or?
It's very similar. It's an opiate. We know a lot less about it, to be honest, than we do, some of the other drugs. And we certainly don't know what long-term effects are. We know that it can cause, liver failure. We know it can cause brain impacts. But we don't, it hasn't been studied.
I think one of the things we heard at the Train the Trainer, one of our hospitals sent several of their ED health educators. And one of the things we heard is, well, what are the distinct symptoms? And like, we typically just consider kratom when someone's having delirium, right? Like, oh gosh, no, if they're at the delirium stage, like you're missing a ton. And we're so trained to say, okay, what is the distinct telltale sign that this is that? And it's not, it can present as so many other things.
And you have to ask. You have to trust the patient. You have to ask the patient, and a lot of times it's not even part of our screening. And I think now, thanks to our public health team, there's more community awareness about it. But it's the kind of thing where patients might not even mention that they're using it because it's like a food product that you're able to get. So they don't always tell us that they're taking ginseng unless we ask them. And so they wouldn't necessarily bring this up when you're talking to them unless you specifically ask, have you used?
But a lot of them are marketed as energy drinks, right? And so I might say, oh yeah, I take an energy drink every once in a while. But what you're left not knowing is, oh, it's actually had kratom in it. And we purchased several products, and the term kratom is so varied, you would just never even know.
We're thinking it's Red Bull.
Yeah.
Any other questions?
The other clarifying point that is important to make for our community, and if you're having this conversation with other folks in your networks, is this conversation between natural leaf kratom and 7-OH. And the natural leaf folks are continuing to say, well, 7-OH is synthetic, 7-OH is the bad guy. Yes, 7-OH is more potent than what is being distilled from the natural leaf, but it is still the natural derivative. It is still the natural active alkaloid in kratom. So when your body consumes natural leaf kratom, it is getting 2 primary alkaloids and 2 secondary alkaloids. The 2 primary are metrogene and 7-hydroxy metrogene, or 7-OH. So it's a naturally occurring alkaloid. When your body is metabolizing the higher concentrated alkaloid known as metrogene, your liver is actively making that metrogene into 7-hydroxy or 7-OH. And so your body, your human body, why this drug is effective as an opiate is that because your body is making the more potent opiate in its own liver. And so when someone says, well, it's natural leaf is safe because it only contains, metrogene, that's a misnomer because your body is actively making 7-OH. It is actively, concentrating that within your system. And so folks we know who are not sticking to the 1 bottle a day or 1 can a day of their natural kratom beverage will have the potential for not just addiction, but for potential overdose because their body is actively making more potent alkaloid naturally. And so it is just something that we need a hell of a lot more research on. We need a lot more control over. And we're operating in a world with 0 regulation on this stuff. And that's why we're taking action now.
I would think that any legitimate business would be very concerned with liability. If a person sells a dangerous product, they're liable. If you oversell alcohol and then somebody gets in an accident, that bar can be liable. And if I'm a store selling this and somebody dies from it, it seems to me they'd be liable. It seems to me their insurance company ought to be giving that some notice that they're not going to cover it, or
That's a good thought. I hadn't even thought of that.
We've heard a few anecdotal examples of businesses saying, I tried to carry this and my insurance told me they'd drop me if I did.
what's that?
We've heard a few instances of businesses saying, I tried to carry this and my insurance found out and threatened to drop me. But I've been surprised about the liability piece too. The way I understood Montana's third-party liability law, it is very specific to alcohol. And so I don't know that this would.
Well, if you sell any product,
Okay.
you have back to the order.
Then it would, okay.
If it's dangerous,
Yeah.
liables.
Yeah, and that's part of the education we do. I think we included the fact sheet in here at the bottom. I think we, I don't know if we used the liability piece, but we talked about, making sure that our sanitarians are warning them of that, or just saying, be careful here, because just like if someone gets E. coli from your restaurant and ends up in kidney failure, in theory,
That's why I think the notice is very important. It's good you mentioned there had been deaths, so they were on notice that it's a dangerous product.
a lot of establishments are what we've dubbed kratom curious, right? It's a money maker. It's part of this non-alcoholic wave. And they've been told it's a safe non-alcoholic product. And so they'll say, oh, I serve it to people when they're overserved with alcohol. It's terrible. You're definitely not supposed to do that.
Jim, in regards to your question and Megan's comments, some time ago, and I haven't looked lately, but some time ago, I decided to look into this from the scientific perspective. And I was quite surprised at how little data were available on this, just pure science. And it's probably still a big gap. If I were back at my old institution, Primary Research Institute, I would have been putting out grants to try to study this in monkeys to get some really good, valuable data on this. And I think it's still missing. And so the general public can now look upon this and give me a hard time because I'm saying we need more research. It's what scientists always say. And they say, well, we'll just give it a try until science can tell us that there's an issue here. And it's going to continue to be a problem. And there are a lot of data gaps in these products. I was surprised at the time.
And we've even talked to the Tox Lab of we're going to take our products we bought as show and tell. I'd love to test them and see if what the product says is in there is actually in there. But what we've learned from, we had the gentleman who's the statewide cannabis control board inspector come to a staff meeting. And he was like, even if they give you a certificate of authority or, you know, authenticity and things like that, it's all garbage. It's not accurate. So that's the other piece, is with it not being regulated, you don't even know if what you're really consuming is just this amount of nitrosamine. Some of the products say contains lead. Doesn't say they contain lead. It just says contains lead. Crazy.
You know way more about what's in vaccines, it turns out. I'm just saying, you know, share that info with your friends. Vaccines, way more research.
Good point.
Yeah.
Good.
a great point to end on. But if you guys have questions, definitely let us know. This will continue.
Yes, thanks, Melissa.
Thank you, guys.
Also, a question just about, and it may just be one voice, but seeing a pharmacy saying that this is safe and you should be, this RiverStone is out of line. Like, how do you combat somebody? Because I can see somebody being like, well, if the pharmacy says it's okay, it's okay. So how do you combat that?
I mean, I think we just reinstate the facts. I personally take the facts of I'm a mom. I wouldn't want anyone on my team, in my community, consuming something that I don't understand. My kids shouldn't be able to go to the convenience store and grab it. You know, that's my big thing. How you would answer that?
I'll respond to bullies. And people that call me names, we're dealing in the facts, and he's not based in reality. And so people can say whatever they want, but the law is the law. And like I told the county attorney and many of our state legislators, I said, you know, what law do you want me to follow? I think I should follow all of them in the state of Montana and in federal regulations, regardless of whether I agree with them or not. I still have to follow them because that's my job. And so I don't get to pick and choose what regulations we enforce or we don't. The legislature gets to do that. And so if they want to create a new law for me to follow, like they have done for the past 5 years, then they can do that.
We could send Brent in to tell them what their liability is. It's not a company.
I think we learned in public health, you have to share the facts in the law, right? That is our job. You're a government agency. We follow the law. But I also like to add the personal connection of, you know, I care about you as a member of our board of health. Can I talk to you about what I know?
It was surprising to me, I guess.
Yeah.
Yeah.
Not who I expected to be making this fuss.
Okay,
Thank you, everybody.
Thank
Thank
you,
you.
Melissa.
let's cover the things that I unintentionally overlooked about it and the things that I intentionally overlooked. First would be governance committee. I forgot to get approval of the notes of the minutes. If we could have a second. All in favor? Opposed, same sign. Hearing none, that passes. We have a proposed board meeting calendar for 2026 in front of us, which we need to approve.
Second, knowing that it's changed.
Yes. All in favor?
Aye.
Opposed, same sign. Then we have the conflict of interest statements. Most of you, if not all, are familiar with it. Aaron, have you seen this before?
I think so. I don't remember signing them, but I think it's signed them.
So do you have them here to sign, Gary?
Yes.
Carrie, do you have a way to for me to sign it remotely?
Yeah, I can send you one, or you can sign it next meeting.
I'll still be away next meeting.
Okay, I'll send it to you. I'm just gonna make some more.
Anybody have a joke?
What loses its head in the morning and gets it back at night? A pillow.
Oh, no. Don't start with that. We got 15 minutes. I can go on a rant about kratom or vaccine.
Why did the chicken cross the lions? To get to the other pride.
Okay, let me recover this meeting. Well, Carrie looks for the, she's gonna grab a couple copies.
My kid just got a dad joke book, so
We've been working on. Any comments about the meeting this morning or the meeting last night,
Tuesday night.
Tuesday night? Time flies. Any comments about baseball free agency signings?
What about the, Buffalo Denver pass intersection there? What do we think about that?
My wife's from Buffalo. And
My wife and
I went to school in Colorado. We purposely, she went and visited the grandkids the weekend of the ball game, so we weren't watching it together. It could have been brutal.
My daughter is a Bozeman alum, an engineer. Her husband is an engineer from South Dakota State. They sometimes have to watch that game in separate rooms.
About those Bobcats.
Yeah.
2 block kicks, man. That's a heck of a. No, we haven't adjourned yet.
We can sign these things after they adjourn. They let
Yeah.
others disappear.
Let's adjourn.
Yeah.
We will adjourn. There's no other
Because
business.
if we have to put these jokes into the record.
Yeah.
I do